Hello, my name's Alison Porter from Swansea University Medical School, and this presentation is The Paramedic Will See You Now, Understanding New Roles in Primary Care. It's talking about a bit of work that we've been doing in partnership with the Welsh Ambulance Service Trust, colleagues from across Swansea University and also Cardiff University. So what's going on? Well, as part of a sort of wider move within healthcare in the UK, which is towards people adapting their roles and people from different clinical backgrounds taking on new roles in delivering healthcare, there's a bit of a policy move towards paramedics working in a primary care context. So rather than responding to 999 calls, they're actually based within primary care settings and dealing directly with patients via the primary care model. But there's no one model for how this is happening. There's quite a lot of different innovation going on across the UK. So we have started the ARRIVE evaluation, which is a feasibility study, a first step in developing more definitive evidence base, looking at what happens when you have paramedics delivering primary care. What impact does it have from a patient point of view, from a service point of view? And before the beginning of that, we conducted a small qualitative study, which is what I'm talking about today, which wanted to identify sites across Wales where paramedics were working in primary care, what we call PPC, and describe the characteristics of the intervention and the range of models that were being delivered. And then to develop a logic model to describe PPC and its potential impacts, to help us with our evaluation and also help us to understand how it might make an impact. So we started off by interviewing 20 stakeholders from across Wales who were involved in planning or delivering models of paramedics in primary care. Interviews recorded and transcribed in full, and then a thematic analysis. Once we'd done that, in those heady days when you could get people together in a room, we invited 24 people to come together at Sophia Gardens and gave them lunch and talked about their perspective on how this intervention worked. So people who were working in primary care, the ambulance service, community health, and also, very importantly, patient and public representatives. So there we... based on what they told us, we developed a finalised logic model and also talked explicitly about outcome measures for the evaluation. So what we ended up with was a logic model which describes how paramedics deliver direct clinical contact with patients. So we're not interested in this context in paramedics taking a role in planning or designing services, but actually interfacing with patients. And the model considers the relationships between the broad contextual factors, the activities which the paramedics are undertaking, the various aspects of the input, mediating factors, and then the outcomes from the point of view of patients, staff, and the wider NHS. Which all gets condensed in this model here. So you see at the top, we've got the context, which is ageing population, increased multimorbidity, and of course primary care practitioners with an increasing workload, difficulties with recruitment, the time bomb in terms of retirement of a generation of doctors. And then this broader move towards expanding the roles of allied health professionals and training and educating them to take roles which are beyond what traditionally has been their scope of practice. You've also got, from a management point of view, a contractual requirement to deliver primary care, which includes home visits, which can be very challenging. And from a patient perspective, well, it's difficult to get appointments. How can those appointments be fulfilled? So in the left-hand column, we've listed the inputs which people talked about, which could vary from site to site. So, for example, who is delivering this care? Well, it could be a registered paramedic, a qualified person, but not with any additional expertise for working primary care, or in some cases it could be an advanced paramedic practitioner, an APP, who has taken on additional training. Also part of the picture, really important part, are the existing practice staff, the GPs, practice managers, nurses, other staff who are helping to deliver this model of care. We wanted to think about funding going in. Where is it coming from? Is it sustained in the longer term? There has been some kind of short-term funding through from the Welsh Government for some more experimental models of delivering this care. Practical things, like in some cases the paramedics are wearing uniforms, and then they need vehicles to travel in, equipment to use, and then insurance and indemnity cover. This depends partly on who they're employed by. To set up one of these models of care, you need paperwork, service specification, job description and contracts, and formalised governance arrangements for how it's going to work. Accessing patient records, you need IT hardware and software. You need training and induction for the people delivering the care. You need leadership, you need mentoring and support. So once you've got all that in place, what are these paramedics doing? Well, again, there's variation within the items listed in this central column. Many places they're doing home visits, some places they're doing in-practice appointments. They may be doing telephone consultations. They might contribute to multidisciplinary teams talking about patients. They're also spending some of their time doing professional development, maybe passing on their learning to other people or improving their own learning. They might be doing triage, face-to-face or on the phone, or picking out from a list the patients that they're going to deal with. Rather than responding to calls, they might be doing proactive patient reviews, identifying patients in need of longer-term care. They may be doing particular clinical activities like delivering vaccinations or taking bloods. And in terms of outcomes, what kind of things can this model of care achieve? And what kind of things should we be looking to measure to see what difference it makes? Well, in the short or the medium term, we'd hope to see potentially an increase in the number of appointments being fulfilled from that practice. A reduction in the time to a home visit that a patient has to wait, an increase in patient satisfaction, an increase in staff satisfaction, potentially associated with some of the workload being taken off the hands of the primary care staff. And then potentially, in the wider picture, can doing this lead to a reduction in the number of 999 call-outs because it's better proactive care, and ultimately the number of emergency admissions. So in the longer term, what else might we hope to see? Well, overall, a reduction in costs. At a really basic level, a paramedic is paid less than a GP. Does it work out cost effective as part of the bigger picture? Might see more sustainable healthcare, an increase in staff resilience, a more integrated workforce. Some of these are easier to measure than others, clearly. And overall, there's going to be quite a lot of mediating factors which will affect what's going on and what kind of outcomes you might see. So this is to do with the operational area the service is being delivered on, and also the model. Is it what's known as rotational? This is where you have paramedics being employed by the ambulance service, but working, say, 2 days a week for the ambulance service, 2 days a week in primary care. Or will they be employed directly by the practice, by the partnership, or by a health board? There's lots of different possibilities. You also need to think about the length of intervention. There's a lot of new work going on at the moment, a lot of experimental work, some initiatives we know of which have already ended for all kinds of reasons. The suitability of patient selection may be out of the hands of the paramedic. How can that affect what impact they can have? Are patients aware of what's going on and accepting? And so on and so on. So you can see there's a whole bunch of different things which potentially could have an impact on the intervention and what difference it makes. So that was all a little bit dry. I just thought I'd throw in a couple of quotations which came from those interviews, just so you can get a feel of what it's all about. So one of them's from a paramedic who's doing this kind of work, who's feeling very positive. I think the patients are a lot more satisfied. They feel as if they've had a good consultation when they've had specific tasks done. They feel as if we've been thorough with them. Potentially these paramedics are able to spend more time with patients than a doctor can. That had an impact. And then from the point of view of a clinical lead, thinking about what's special or different about a paramedic maybe compared with another healthcare professional. They're used to going into any situation. not knowing what's facing them. So they've got that sort of inbuilt confidence to walk into the patient's home and be faced with anything. So what's the implications of this work? Well, this is a rapidly developing area of provision in primary care across the UK. A lot of work is looking at it, in fact, on the research front. But there is this huge variation in nature of models, a thin evidence base. So what we've got here is the first step in developing an evaluation, which is going to really give us a better idea of what difference this model of care makes and the best way of delivering it. If you want to know more, that's me, Alison Porter at Swansea University. There's my email address, and we'd be really pleased to hear from you if you want to get in touch. Thank you.